Welcome to Cancer Explained with Central Care Cancer Center. It's likely that someone you know has been diagnosed with a form of cancer. Learn more about specific cancers, their risks, signs, symptoms, and treatment options by listening to Cancer Explained.
Hello and welcome to Cancer Explained with Central Care Cancer Center. My name is Leanne Powers. I'm the Marketing Director for Central Care, and with me today is Radiation Oncologist Dr. Perez-Tamayo. At Central Care Cancer Center, we are dedicated to keeping expert cancer care close to home. We have state-of-the-art facilities throughout rural Kansas and in Missouri. Whether you need radiation or chemotherapy, a second opinion, access to clinical trials, financial counseling, or other supportive services for yourself or your family, even genetic screening for cancers, Central Care is here for you. At any time, feel free to email with any questions or comments to askdoctor@cccancer.com. That's askdoctor@cccancer.com. Well, our discussion today centers around a pretty important topic. It's lung cancer. First, doctor, I thought maybe we would just kind of, we do this from time to time, have you just explain a little bit about your background and a radiation oncologist and why maybe lung cancer in general is just an important topic here to discuss.
Well, this is very important, Leanne, and thank you for having me today. Radiation oncology, think of it as a surgeon versus medical oncology. We treat the local and regional area. What does that mean? It means the primary where it started and where it spreads locally, like the lymph nodes. While the chemotherapist or medical oncologist treat the system, meaning they treat where this would go into the bloodstream, which would include other organs like the liver, the bones, the brain, and so forth. So we are actually are complementary. We treat different areas, but our aim is to get rid of the cancer in all of the regions where this could be.
As far as your background goes, though, to prepare for this, I mean, you go to a lot of school, don't you?
Yes, we actually do 5 years of after medical school of radiation oncology. The first year is an internship where you do basically just internal medicine, and then the rest of the time you spend doing basically cancer and cancer studies, and cancer having with a focus, of course, in radiation oncology, but you study all aspects of cancer, what we call the pathophysiology of cancer, where it goes, how it travels, what it wants to do, because there is not only the science of cancer, but the art of cancer. So it is very rigorous. And after that, you can do a fellowship, which means you specialize in a particular part of the body. Like in my case, I did a fellowship in genitourinary cancer. After I did my general radiation oncology, I did that in Holland. So it is a long haul.
It is. Well, we're glad that you're here, that's for sure. When it comes to lung cancer, the symptoms and signs, I think something that maybe you have mentioned to me before is that when you have symptoms for lung cancer, sometimes it's already too late.
Yes, this is a silent cancer, and this is why now most insurance companies are understanding that we have to get it before it's even symptomatic. And the symptoms include coughing, coughing blood, just coughing sputum, losing weight, and then, of course, there's pains and other things that can happen, shortness of breath. But you don't feel anything when it first starts, absolutely nothing. And therefore, if you are eligible for the screening portion of it, you should commit to it. And what are the particulars? You need to be between 50 and 80. You have, you're currently smoking, or you quit 15 years ago. You have a 20-year pack history. What does that mean? It means you smoked a pack a day for 20 years or 2 packs a day for 10 years. And so once if you are eligible for this type of parameters, then it's a very easy exam. It's a low-dose CT scan, which doesn't hurt. It's like an X-ray, but with a special machine. And if you get a cancer that is small, like a centimeter, 2 centimeter, which is about an inch, it is easy to take care of. And the treatment is simple. Sometimes you don't even have to have surgery, and it's almost 100% curable. We most of the time actually see the patients who are stage 3. And these are no longer as curable as stage 1 and 2, where they're almost 100% curable. It drops to 10%. So why would you wait? I think that if you have been a smoker or you're currently a smoker, please go and get yourself screened. It doesn't hurt. It takes only a few minutes, and you can actually save your life.
That's what I was wondering too. Like we say a low dose CT scan, so it is just a minimal dose that it shouldn't affect your daily, capabilities in everyday life. And you would do this yearly if you are a smoker, or if you fall in for those guidelines. That screening.
Yes, if you are a smoker, you have to do this yearly. And by low dose, it means that it is a quick scan. And it will take about 15-20 minutes, and it doesn't hurt. And it will, within 5 years, if you are doing this 5 years and you've quit smoking, you may be able to stretch out the time between CT scans. But if you continue to smoke, you're going to continue to have the screening, CTs. And, they're minimally invasive. You don't get anything painful. And again, if you can get this seen early, you're highly
Save your
curable.
life. Yeah, definitely. Women, men, older, younger, I guess.
It used to be more of a man's disease because women did not smoke. Unfortunately, it has risen to almost the same. And it is mostly on the older population because it is a longer time of smoking. And it is the exposure of the cigarettes, whether it's secondhand or, just your own smoking, that makes it more prevalent. Now, smoking does not only affect your lungs, it can affect your bladder and other parts of your body, and it can produce cancer. So the toxicity of the tar and nicotine is something that will affect your lung, but also there is radioactivity that is given off of the cigarettes or the non-cigarettes now that are the e-cigarettes that are now popular.
Yeah, the vaping.
So you're not doing yourself any favors. If you chew tobacco, you also can get not necessarily lung cancer, but you get cancer where this hits the mucosa of your mouth, lips, and throat. So basically, nicotine and tar will give you cancer.
It's just so important, I think, just to go ahead, get the screening done. And if you can catch something early enough, it's just such a valuable, like I said, to have a better quality of life, catching it versus like a stage 3 versus, stage 1.
Absolutely, Leanne. And if you have any questions about this, just give us a call. We'll give you the number at the end of of this, and you can ask questions, see if you qualify. Sometimes people that are in jobs, for instance, bartenders that are exposed, or the people that burn wood or trash for a living, they may also be at high risk.
Environmental aspects too. I'm just trying to think of pollutants and
yes,
such.
Some of the people that actually are minors in particular are actually eligible to have coverage for cancers of this type.
Is there a genetic component to lung cancer? Say like
there
your
is.
father had lung cancer or a sibling, yeah?
Yes, there is. But usually it's an adenocarcinoma. They have a certain look to them. They're usually multiple, meaning they are not just one, but they have several in both lungs. And you have a history of family and these are not necessarily nice. They're kind of aggressive cancers, and they can start in different parts, but you can make them become even more prevalent by exposing yourself to cigarettes or radon, for instance. One of the environmental sources of cancer is radon. So people that have family history of cancer can have the possibility of seeing it even earlier in their life by having the smoking.
Again, I'm with radiation oncologist and president of Central Care Cancer Center, Dr. Perez-Tamayo, and we're talking about lung cancer. Okay, so doctor, I have a question for you. I just want to pose to you. So walk me through about how you can start with lung cancer, but in some cases your cancer may start elsewhere and spread to the lung. I mean, is it more common for lung cancer to start in the lung or maybe elsewhere in your body and then travel to the lung?
Leanne, we've talked about this in other sites, like is it is the cancer of the brain or in the brain? This is another one of the same story. When you have a lung lesion, you don't necessarily think, okay, this is coming from the lung, or is it going from the colon, let's say, to the lung? So you have to do a workup. Lung is like a sponge. So if you can imagine the heart receiving the blood from all parts of the body and then sending it out into the lung to get oxygenated, and then coming back and sending it up to the brain, up to the liver and the kidneys with a fresh oxygen in the red blood cells. Well, it can be that cancer that is from elsewhere is coming to the heart, and the heart is a pump. It pumps it into the lung, and it stays in the lung, and it actually has never been in the lung, but coming from the colon, and then it starts to grow in the lung. That is a different story. So actually, it traveled through the blood system into the lung. We're talking here about something that actually started in the lung and then started to grow, and then it went the opposite direction. It went to, and usually actually it almost never goes from the lung to the liver without passing through the lymph nodes. So if you have a stage 3 cancer, that means that your lymph nodes, which are your filters that filter impurities, go into the hilum, which is where your windpipe divides into the right and left side of the lung. And then it gets into the mediastinum, or the middle of your body, into the lymph glands. The lymph glands think of them as stations in a train that go to the next train station, that go to the next train station. So when these are involved, usually it's a different system than when the blood is involved. And all of these have to be treated to be able to have a chance to get rid of the cancer. Now, the cancer, when it starts involving the bloodstream, it can involve the brain directly. Why? Because a little bit of it goes into the heart, and then it basically pumps into the brain. And then it can also go into the liver or the kidneys or the adrenals or the bones by pumping to other parts. But the lymph glands are not necessarily full of blood. In fact, they're full of lymph, which is a fatty substance. And radiation is especially good about cleaning those up. So many times when we see stage 3 cancer, which is the most common stage we have to treat with the 3 modalities, meaning, the radiation to the primary, number 1, to the lymph nodes, number 2, and also to the blood. So we have to treat all the areas and clean them up. Surgery is really reserved for cancers that are early on, where we think that we can get them by just removing the primary site. Sometimes we have to stage the cancer. In other words, we have to look at, is it really just in the lung and nowhere else, before we go and think surgery is a possibility. We can do that various ways. We can do it with a bronchoscopic exam, where people use ultrasound to see if they have lymph nodes and stage them that way. We can do it with radiographic means, meaning CAT scans and PET scans and other methods. And we can even do them with surgical procedures like mediastinoscopies, where actually a scope is introduced around your trachea, and then we can actually map out if there's any lymph nodes. Surgery really needs to be applied to the person if it is going to make a difference, because most of the people that have cancer of the lung have a poor lungs because they have emphysema. So you don't want to make the person have worse problems if it's not going to make any difference in their life.
What are the types of lung cancer? I've heard of, of course, non-small cell, and there's...
It's divided into 2 main categories. Non-small cell, which means that the cell looks large or flat, like an adenocarcinoma or large cell, or a squamous cell. These are all non-small cell. And then the small cell, which look like oat cells. They look like oats. That's why it's also called oat cell carcinoma. Huh. And they have a very different way that they like to spread. They come from different cell types. The oat cells they're called neuroendocrine cells. They come from a different part of the embryologic development, versus the adenocarcinomas, large cell carcinomas, and squamous. People that are smokers can get any one of these. The people that are family history more, that are non-small cell, they usually get the adenocarcinomas. And there are some cases where you have a mixture of all of them. You also have other cancers of the lung, which are none of these, that are from unusual situations like sarcomas and melanomas and lymphomas, but those are very, very rare. So really, first of all, you have to divide the cancer into a small cell or non-small cell, because the small cell carcinomas are not ever treated with surgery. They're treated exclusively with either chemotherapy alone or chemotherapy and radiation. If you have the non-small cell, then it's when we have to map out the patient and see where they're at.
So lung cancer is essentially the second most common between men and women, cancer in men? I would think prostate in men and breast in women? Or
Yes, and it depends on what population you look at. And of course, if you exclude like skin cancers and so forth. But it is very common. And I don't know that it is getting more common. I think it is, if you look at like certain suburbs of Kansas, you see more than others. Interestingly enough, you don't see it as much in the rural areas of Kansas, while you see it more in the like Wyandotte area. So, what exactly is making people smoke more in those suburbs? I don't know, because they're starting. Actually, people are starting just as young as they used to be. That has not changed. But I think economy is hitting it hard, because now it is very expensive to smoke, and perhaps that is going to be what's going to make people at least cut down.
Right. I know we've talked a little bit about the various stages of lung cancer versus, you've catch most of yours at stage 3, but with the screening, you might be able to catch it early enough with stage 1. But is there a survival rate? What the difference between?
Yeah, it's huge. Stage 1 is almost 100% curable. Stage 1. Stage 2 can be in the 90s. Stage 3 is from 10 to 20%. Stage 4 is always fatal. So it's such a huge spectrum. And we do have new drugs and new ways of perhaps extending the life or the symptom-free survival of patients. We have new immunologic agents, new receptors. And by receptors, and you'll see this in a lot of cancers, receptors are these special, let's say, keys that the cancer has, that you can have a medication that enters or fits this key and is able to direct it in a different way. There are certain things that cancer does, like it can produce blood cells, like capillaries, to feed itself more. It can attract capillaries to make it grow. And maybe you can have something to shut that down, or you can have these tendencies that they have to become stick together and make a ball. Well, if you can make them not do that, then they will dry up. So there are things that are being developed that are causing disruption of the receptors, that these pathways that the cancer has. And I am sure that maybe someday we will have more of an answer. The unfortunate thing is some of these pathways also are seen in normal cells, and therefore you have a problem, with a balance of what you can do with these cells that is not going to cause problems with other normal cells.
This makes sense. Okay. I'm Leanne Powers with Dr. Perez-Tamayo from Central Care Cancer Center, and we've been talking about risks and symptoms and lung cancer in general. But, Doctor, I kind of want to talk a little bit about prevention and treatment. Of course, as far as prevention goes, stop your smoking or being around those kind of pollutants that could, help lower your risk or change maybe the risk factors that are in your control. But what other types of cancers can travel to the lung, or can non-small cell or small cell cancers show up in other organs as well? I think we kind of talked a little bit about that, but why don't you highlight that again? Is it mostly like like you had mentioned colon going to the lung, or brain maybe going to lung, but is there others?
No, brain usually doesn't go to lung,
okay.
but however, lung cancer often goes to the lung. In fact, so much so that when we're talking about small cell cancer, we treat the brain even when it has not gone there, because it is very often in the brain microscopically. So most cancers can go to the lung, again, because the lung is that sponge I talked to you about, where it could trap a cell, like think of a colander that just trapped that cell and it starts growing. So any cancer of any sort, whether it's colon, ovarian, any cancer can grow, or even melanoma that is from the skin can go to the lung. But this is why it's so important to do a complete workup, because you don't want to subject anybody to any treatment before you know what it is.
And those treatment options, I mean, include, I guess, depends on where that location of the tumor is.
Well, not the location as much as where the patient is in its stage. So staging the patient is paramount to what is going to be the option for the patient. So first of all, you have to do the staging, but you start at the beginning. Let's do the screening first. And you have to go through your family physician. And here I have to encourage people to be their own advocate. If you are not offered this service, which, unfortunately, I think people are busy, they don't really perhaps ask you the questions that will get you into the screening, which means that you've been smoking for the last 15 years, at least a pack a day for 20 years, or 2 packs in 10 years, that you're 50 and 80 and you're still smoking. All of these contribute to being a candidate for the screening. And if you don't ask for it, it's not going to happen. So, you may think you got away with it, like, yay, nobody asked me, I win. No, you win nothing.
Right.
You will lose. So please make sure that you ask for it by name. I am a candidate for cancer screening, and it's simple. We offer it. And here, Leanne, why don't you please mention what locations are available?
And for that matter, doctor, if someone gets their report back, you would be willing to go over their report with them too, correct? Here
Absolutely, because, this is where the second step happens that can be done in a way that can be problematic. And why I say that is that if you're someone that has insurance that is not necessarily going to cover the entire process of the staging, you have to do it in an order that makes sense to the insurance company. Because if you have something done before the right sequence happens, you may not qualify for the entire staging process. And then it's going to come out of your pocket. And in addition, we do have grants. I want to mention this and highlight. We have grants that you may qualify for, and it may give you that incentive to do this the right way and get yourself to the right position to be without the burden of having extra expenses that you don't need.
So with that low-dose CT scan, I mean, it's around most of where our clinics are located too. I mean, where central care clinics are. I mean, here in Emporia, Newton Medical Center, St. Catherine Hospital in Garden City, of course, Providence Medical Center in Kansas City, and then there are also other locations in Topeka, Wichita, and Great Bend as well. But it's just so vital to ask for it by name and get your provider, your primary care provider's referral in order to get that low-dose CT scan.
And Leanne, you mentioned something very important that's dear to my heart, is that and you get your CT scan at the hospital, which they have a wonderful machine and perfect low-dose CT and radiologist. You don't have to travel to a large city to be facing a staging that can be done at home. And the reason why I say this is that once you start with a situation where you have to travel, you're going to have to continue to travel, and this is a long haul. This can, be something that you have to do for days and months at a time. And if you're working, and usually, you may be young, or you may need to have people taking you back and forth, it can be a chore. So stick to home. There's no reason for you to travel. we can get everything done at the hospital, and people are there to be able to help you in any way you need.
So here's another question for you. Let's say you had non-small cell in your left lung and were treated, and you got a clean bill of health, essentially. But that cancer could come back, maybe on the other side, correct?
Yes, once you have one cancer, you are absolutely at risk for a second one, because whatever happened to make you have the cancer, the exposure of X or the family history, you can have it on the other side. So you have to have a follow-up, and the follow-up is every 3 months, and usually it's some kind of radiographic examination, whether it's a CT or PET scan. And again, do you want to be traveling for hours on end for something? And then, you need to have somebody that is going to be available. Let's say you have problems at 5 p.m., all right? Then what happens? So I would say, please be sure, this is like a marriage. You want to have someone that's going to be by your side and available to every need you have.
Be your own advocate. Consider a low-dose CT scan like your yearly mammogram or your yearly prostate exam, for that matter. And especially if you fit in the criteria for the low-dose CT scan, and just get it done and help prevent possibly, coming to see you at stage 3 versus, stage 1. So.
Absolutely. You can be cured in almost no time and have the guarantee that this is not going to come back, versus having to go through chemotherapy, radiation, and perhaps still die anyways when you had a great opportunity if you would have done this simple test.
Right. Anything else you'd like to add about lung cancer before we wrap up?
Well, lung cancer can present in numerous ways, but it can also present when it's already stage 4. And this is something important to know. Sometimes people don't think they have lung cancer because they have pain in their back. They have a fractured, let's say leg. They have headache with nausea. And you think, okay, maybe something in my stomach, maybe. And it actually is lung cancer that has already escaped from the lung to those parts. So, if you feel that just over-the-counter medication is not taking care of your symptoms and they are ongoing, do not hesitate. Let someone know, and don't wait till the weekend at 5 p.m. to come and see someone so that we can we can find out what's going on.
Great advice. Thank you, Dr. Perez-Tamayo. Let's just hit the screening criteria again from the American Lung Association regarding the low-dose CT scan. It's those at high risk, you can reduce your lung cancer death rate by up to 20%, because a low-dose CT scan will detect the tumors at early stages when they are most likely curable, like Dr. Perez-Tamayo was talking about. A high-risk person is defined as anyone from ages 50 to 80 years old, and you've got a 20-pack history of smoking 1 pack a day for 20 years or 2 packs a day for 10 years. Or you're a current smoker, or you've quit within the last 15 years. And again, you can get that low-dose CT scan. You have to get a referral from your primary care physician, but Newman Regional Health in Emporia, they offer low-dose CT screening. Newton Medical Center in Newton, St. Catherine Hospital, Garden City, of course, Providence Medical Center in Kansas City, Kansas. There's other locations too in Topeka, Wichita, and of course, Great Bend, and as well as Kansas City too. But get that primary care physician referral, get yourself a low-dose CT scan, and try to help prevent yourself from being diagnosed with the stage 3 or higher lung cancer, especially if you are at a high risk. Well, we appreciate you taking the time to listen to Cancer Explained with Central Care Cancer Center. With facilities throughout rural Kansas and in Missouri, Central Care offers complete cancer care, all under one roof, so there's no need to travel far for the best care. Whether you need radiation or chemotherapy, access to clinical trials and novel treatments, maybe financial counseling or other supportive services for yourself or your family, even a second opinion, Central Care is here for you. You have a choice. Bringing that expert care to you is an important component to the success of your outcome. Being surrounded by your family, your friends, that can be the factor that elevates your treatment. Feel free to reach out by calling 800-592-5110, or you can visit us online at cccancer.com. For Dr. Perez-Tamayo and all of our amazing providers and nurses, I'm Leanne Powers. Thank you for listening to Cancer Explained with Central Care Cancer Center.
You've been listening to Cancer Explained with Central Care Cancer Center, offering expert cancer care that's close to home. Central Care Cancer Center has clinics throughout Kansas and in Missouri. Central Care Cancer Center, online, cccancer.com.